experiences are. So about these breakout rooms, I know that many of you are not native English speakers and might feel a little bit shy to contribute to breakout rooms. I am not a native speaker either, so I understand this feeling. But it would be nice to contribute. It's nice because you learn other people than just the speakers, and you get some more experience in what it is on the working floor. What we're talking about. So I would ask you, when we go into the breakout rooms, to turn on your microphone or your camera too, that would be even better, to just briefly do a round of introductions, say your name, your country, any experience you might have with Safety 2 or the theme that we've just been talking about, and then discuss with each other what the speakers will have asked you to discuss with each other. So that's about the breakout rooms. There's a conversation box on the right side. I see some people have already been putting stuff in there. Helgi from Iceland, welcome back. So please use that conversation box to add questions or suggestions. After each breakout room, we will come back with a plenary discussion in which we will try to answer some of the questions that you've put into the conversation box. So that is what we're going to do today. So let me just go to the speakers, and I will ask Mary to introduce herself, then Axel, and then Jeffrey, because Jeffrey will go on with a brief introduction on what Safety 2 is. Mary.
So good morning, everyone. I'm delighted to be joining you today. My name is Mary Patterson. I'm a pediatric emergency physician, also Associate Dean of Experiential Learning, and as of tomorrow, Interim Chair of Emergency Medicine. So I have a lot of experience, real life, with adaptability and resilience engineering. So delighted to be joining you again.
Delighted to have you here, Mary. Thank you for joining us. Axel.
Hello, I am Axel Roos, out of Jönköping in Sweden. My professional background is that I'm a surgeon. I don't do surgery anymore. I am the Chief Medical Officer in the region Jönköping County in the southern part of Sweden, and I also do some research and teaching in patient safety at the university here. Thanks.
Good morning, good afternoon, good evening. I'm Jeffrey Braithwaite. I'm Professor of Health Systems Research, and I direct the Australian Institute of Health Innovation in Sydney, Australia. I'm also President of ISQUA, the International Society for Quality. And although I trained in psychology, I don't describe myself in that way. I'm really a health systems researcher with a great interest, a real genuine interest in safety and improving health systems. And my research is in those areas. So I think I'm invited by the moderator to continue. So I'm going to show some slides really to come to grips with some of the concepts that I think we're going to be workshopping during this session in a bit more detail, especially in the rooms, in the breakout rooms. So that's the title of the session. And the faculty is, of course, the people who you've just been introduced to. The four of us, and these are some of the institutions and organizations that we belong to. You're going to be hearing from three presenters who are presenting to us via video. Professor Kazu Nakajima from Japan, Professor Andrew Johnson from Australia, and Dr. Nikki Damon, who is from the Netherlands. And each of them has an extremely interesting, and even despite only a 5-minute video, a profound understanding of Safety 2 and resilience engineering applied to healthcare. So we're going to be hearing from those shortly. So just a few more words from us, really to tease out some of the concepts and perhaps tease out some of the misconceptions about some of the terms that you'll hear and that we'll use in this session. One is a few words about reliability. The best place to go to for information about reliability is the IHI. Here's directly from the website. It's in quotes from the IHI website, which is in turn from Nolan's wonderful book with colleagues, Improving the Reliability of Healthcare. So the IHI believes that applying reliability principles to healthcare can remedy defects It can increase consistency. It makes for better healthcare processes. It improves appropriate care and improves, in turn, patient outcomes. And IHI is working with lots of hospitals across the world, as you know, and really these are three things that it's trying to do: prevent failure, identify and mitigate failure, and redesign processes so they're, if you like, failure-proof. So that's, in a nutshell, reliability. It's to ensure consistency. Resilience, on the other hand, it's another R word in the English language, but it has a different flavor about it. Resilience is about keeping on, despite all the things that healthcare can throw at us, all the things that a health system can encounter, disturbances, changes that can affect the system and how it delivers care, whether we mean the system as in a microsystem, a team, or the entire health system or a whole chain. And it keeps on keeping on. It sustains required operations. And the best example recently is the pandemic, COVID-19, which the health system in many countries endured, and in other countries did extraordinarily well to flex and adjust and adapt. It's about adaptive capacity. So now the other confusion sometimes is about safety 1 and safety 2. And these are closely related terms to resilience engineering. So safety 1 is the way we've traditionally done safety. It's where the number of adverse outcomes is as low as possible, trying to stamp out harm, trying to make sure things don't go wrong. Safety 2, on the other hand, is where the number of acceptable outcomes is as high as possible, trying to make sure things go right more frequently. And so until we in the Resilient Healthcare Net, and Axel and Mary and I are members of that network from the very start, until we did that in the Resilient Healthcare, few people had actually asked the question and looked at, why do things go right so often? And even today in 2021, might I say, it sounds like a strange question. Why do things go right so often? Isn't the question, why do they go wrong so often? Well, that's safety 1 thinking. And what we help to promulgate is the idea that things go right a lot, and we should learn from that. We should understand that. So, if you want a snapshot slide, this is the one. I'd like to claim, perhaps extraordinarily for some people, that the amazing thing about healthcare isn't that it produces adverse events in 10% of cases, although that's remarkable and obviously something that we have been working on and need to work on further. But the amazing thing about healthcare is, in a system this complex, it produces safe care in 90% of cases. That is remarkable. So that takes us to the work that's done about when things go wrong, and there's lots of that work: inquiries, incident monitoring, RCAs. But when things go right is the full picture and the most common picture of healthcare. And we had decided all those years ago, when we embarked on Safety 2 and resilience engineering applied to healthcare, to understand that and do more work on when things go right. So just briefly, if you think about it, you can say this. You could say 40% of care is in line with guidelines or level 1 evidence. You could say 30% of care is wasteful. You could say 10% is the rate of adverse events. Or you can flip that and say 60% of care is in line with guidelines and level 1 evidence, 70% is well-deployed health expenditure, and 90% is the rate of safe care. So these are the two different perspectives in resilience engineering in Safety 1 and Safety 2. So just by way of concluding these introductory remarks, if your mental model looks like this, if you think about healthcare in its structural sense, then you'll tend to think about reliability and consistency in your approach. If, however, like us, you believe healthcare is better described like that, with lots and lots of interactions and lots of resilient practices going on all the time, then that takes you to understanding a response in terms of resilience. So that's really all we wanted to say by way of introduction, except that you're behind in your reading because we in the Resilient Healthcare Net produce books faster perhaps than many people can read. We're up to book 6 in the Resilient Healthcare series. So if you are behind in your reading, you need to get reading. And this, we hope, is a launch pad for you in this session to look more to Safety 2 and resilient healthcare. So now we're going to do the first of the videos. Just before I do, just a reminder, Safety 1 we've spent a lot of time on. And these are the kind of solutions under Safety 1. Root cause analysis, hand hygiene, medication safety, accreditation. We think all of those things, notice the bullet point at the end, insert your favorite tool, approach, or model there. We think all of those should continue. Safety 1 shouldn't be stopped. Safety 2 doesn't mean stop doing Safety 1. It means in addition to Safety 1, you need to do Safety 2. You need to do things more things going right. So that's all we need to say by way of introduction. There's lots to say in the small group work and in the rest of the session. Professor Kazuo Nakajima is one of the leading people in the resilient healthcare net and one of the leading people not only in Japan but in the world. And she's prepared a short video. I'd like you to look at a few things. This is a story of everyday clinical work. It's a research project that Kazuo is leading. It asks, why do people fail and why do they succeed? The particular example is a pharmacy department dispensing. It shows constraints and disturbances and adaptive tactics. And we'd like you to think about that as you go through Kazuo Nakajima's presentation. May we see that, please?
Hello, ladies and gentlemen. I'm Kazuo Nakajima. I'm talking about understanding of everyday clinical work for quality improvement by redesigning the system based on Safety 2. Safety 2 is a synthetic approach to safety management, pursuing how people achieve intended outcomes in a changing environment and under constraints. We need to understand everyday clinical work focusing on interactions of individuals or subsystems instead of analyzing an incident. We targeted everyday clinical work, specifically medication dispensing and deliveries from the pharmacy department to inpatient wards, although the project was triggered by a medication dispensing incident. We focused on interactions between the two subsystems for medication administration on time. In the medication dispensing unit, workflow is like this. Major constraints in this environment were the limited number of pharmacists and the limited time for medication dispensing and verifications before medication trains leave. Significant disturbances were frequent interruptions of pharmacist work by answering phone calls and handing over medications at the pharmacy counter. We found 3 tactics of pharmacists to adapt to this environment to get the job done. The first one is staffing support from other units within the pharmacy department to complete medication dispensing and verifications by the regular medication delivery time. The second tactic is an increase in the processing power of a particular pharmacist. For example, pharmacist A stretches his capacity of verifications a day, which was by far the best. The third one is navigating a constraint in other systems. The pharmacy department runs medication delivery trains to inpatient wards only 4 times a day because pharmacists need slack in their performances. On the other hand, in inpatient wards on the right side of the slide, nurses also worked adaptively. When physicians ordered urgent prescriptions, nurses often made phone calls to pharmacists to request urgent medication dispensing or inquire about the delivery time. They also picked up medications at the pharmacy counter. Because there was infrequent medication delivery, no information about the progress of medication dispensing for nurses, and no alternative to medication pickups at the pharmacy counter. As a result, pharmacists were interrupted by phone calls every 4 minutes and counter services every 11 minutes. That is, Frequent interruptions in pharmacist work are emergent problems from interactions between the different subsystems of the hospital. To solve such a systemic problem, we implemented 3 interventions colored in red to mitigate the constraints in inpatient wards. Visualization of the progress in electronic patient records, extra medication deliveries by trains when needed, and the use of lockers for medication pickups. After the interventions, the numbers of phone calls and counter services have been significantly decreased. Here is the summary. People work adaptively in a given environment. Adaptive tactics make the system function well, but at the same time, they have potential risks for failures. Describing how people work can help identify systemic problems and their solutions to redesign the systems for quality improvement. Thank you very much.
Okay, thank you, Professor Nakajima, and I think you might even be in the audience. Thank you for preparing that fantastic short summary. So we're going to put you in small groups now, and we don't have any complex, 10 questions to ask you. We really want to see the energy of the small groups and see how you might respond to what we've said so far. So you'll be put in small groups 3 times, as Ian has said. So in this first one, could you just react to that and think through with your small group in the rooms how this might apply in your own world? And particularly, I guess the question I have is how can you use examples like this and the words that I've said to do more things going right in your setting, in the work that you do?
So Hannah, can you set us up in the breakout rooms and make sure that we are back at 11:25 Amsterdam time?
So Ian, you were going to ask a question first, correct?
Yes, that's right. And I can see that we have our delegates back with us. So welcome back from the breakout rooms. There are 2 questions. One question from the group. Jeffrey, you were talking about these books that you produce faster than we can read them. Where, if we want to read them, where can we get them?
So the books are available on Amazon and easy to procure. There's also some summaries of these concepts that I've been presenting on behalf of Mary and Axel. There's a paper in the International Journal for Quality in Healthcare called Turning Patient Safety on Its Head, which I think summarizes quite well some of these concepts. There's a white paper that was produced by the late Bob Weers, Eric Hollnagel, and myself a number of years ago, and lots of the concepts still remain. So if people wanted to start some reading or just add some texture to their reading and not jump into all those books straight away, they could do so by those means.
Yeah, and I think if you Google Braithwaite white paper safety 2, you'll probably find it.
Yeah. And there's lots from Hollnagel too. Eric is really one of the major producers of some of the concepts here, and there's lots from Hollnagel. Yeah.
Super. Thank you, Jeffrey. So a question I have, you said that safety 2 is not meant to come in the place of safety 1. Safety 1 is important. We need the things that we have done to make healthcare as safe as it is now. But do you have any examples of safety 2 interventions that have been working so well that you can actually stop or reduce some other safety 1 interventions?
I think the sense of the resilient healthcare net and us, and I'd actually ask Mary and Axel to answer that question too, is we're not trying to stop Safety 1. Safety 1 and 2 are, if you like, a composite package. You will do Safety 1 when necessary. And there's quite a number of papers in the later books about the fact that we shouldn't stop Safety 1. There's some legitimate reasons why you want to try and do reliability, try and reduce harm, do Safety 1 activities. But Safety 2 is, if you like, a much more look at the whole system. A quick answer to that, and I'd rather have Mary or Axel address this if they wish to. A quick answer to that is, look, everyone does root cause analysis, okay? When there's a second event or a serious event, people will do a root cause analysis. A very powerful Safety 2 question to add, and that's a Safety 1 paradigm. How do we make sure that never happens again? So a very powerful question to ask during an RCA is, how many times did this happen, this procedure, this way of doing things, which created the error, which produced the error, or is associated with the error, how many times did that happen when it went right? And what can we learn from that? So you can even do Safety 1 things, such as RCA, root cause analysis, but ask a Safety 2 question. So we see them as complementary a lot. Yeah. Barry, Axel, would you like to add to that?
I agree. I agree. I would say you have to do both Safety 1 and Safety 2. And Safety 2 is very much about understanding the real work that's going on in reality. And so the Safety 2 approach helps when the Safety 1 approach isn't accurate enough for the complexity that was on one of your slides there, Jeffrey.
And I would echo that. And you may have seen Terry Fairbanks, who's an emergency physician at MedStar here in the States, was put in charge of a series of RCAs regarding people with spinal issues that had developed weakness and required emergency MRIs, essentially the kinds of things like epidural abscesses and those types of things. And he was tasked with looking at a series of cases. But what he did actually was asked to see the last 10 or 20 cases when there had not been a problem, when things had gone well, when things had gone right. And he was able to look at what the resources were, what the timing was, all those issues that enabled most cases to go well. And one of the questions when I'm involved in an RCA, where I'm asked to attend, one of the questions I've started to ask is, so what else was going on when this happened? What other conditions? What was the environment? Because, oftentimes, to your point, most of the time this goes well. And so what is it that enables these things to go well? And what were the conditions that were different this time?
Super. Thanks, Mary. I just saw in the chat an excellent takeaway from one of the groups. Let's focus on the Swiss cheese and enjoy it rather than the holes. I hadn't heard that one before. Thank you, Lisa, for sharing that. Can you go on and take up the presentation?
Thank you. So again, good day. I'm glad to be here. I have the pleasure of introducing a video by my colleague and friend, Andrew Johnson, who's a physician in Australia. He served as the Chief Health Incident Controller at Princess Alexandra Hospital in Brisbane, and he was charged with preparing that regional healthcare system, a tertiary care healthcare system, with respect to COVID preparations. And his video, what I'd like you to pay attention to is his description of the resilience potentials and how he describes their flexible plan, which gave the system and the people within the system space, what we call margin for maneuver. And the third thing that I think was really important in Andrew's video is how they valued frontline healthcare workers. The agency they gave them, they allowed them to exercise their full competence envelope. Particularly, he talks about a goal-oriented rather than a task-oriented approach. And this is something we view as very important in terms of frontline healthcare workers and their agency. As well, they learned from the frontline healthcare workers during as they prepared and during COVID itself. And one of the questions that I've been really pondering throughout the pandemic in my own work and when I hear about others' work is why were frontline healthcare workers able to exercise agency in ways that we typically are not able to exercise agency during the pandemic as compared to our usual work. So with that, let's please take a look at the video.
I'm Andrew Johnson. For the first 6 months of 2020, I was Health Incident Controller at the Princess Alexandra Hospital in Brisbane, Australia, one of Australia's largest quaternary institutions. In that role, it was my job to prepare the organisation for the expected influx of COVID-19 patients and for the impact of COVID-19 on hospital operations. To achieve that, I utilised the resilience potentials described by Hollnagel of anticipate, knowing what to expect, monitoring, knowing what to look for, responding, knowing what to do, and learning, knowing what has happened. In anticipation, we needed to look at the international experience, understand what was happening to our colleagues around the world and the behaviour of COVID-19 down to an individual patient level and at the hospital delivery level. We developed flexible plans around that international experience. In monitoring, we needed to explain those expectations to our staff so that they knew what was expected to occur and were able to advise us when things were not going according to plan. In sharing the plans and the information as it came to hand, we were able to turn our 6,000 staff into 6,000 monitors. In responding, it was critical that from the Emergency Operations Centre, we didn't try and direct specific actions required at an individual or departmental level, rather to explain the outcomes that were required so that those that were working at the coalface, who understood the work that was required and work as it's actually done, were in a position to create emergent solutions to deliver against those challenges. In learning, we needed to apply the Safety 2 principles of establishing what goes well, not just what goes wrong. And we did that in real time, looking at reflecting in action what was occurring within our organisation so that we could do more of what goes well and less of what was not working. The results spoke for themselves. We were able to triple our capacity for receiving emergency patients, triple our capacity for intensive care, and create a 150-bed buffer within the organisation to deal with the expected influx. We're very proud of our results.
Super, great. Mary, would you like to give people something to talk about in the breakout rooms?
Yes. So again, just to reiterate, I think what we heard from Andrew is that they deliberately chose to use the resilience potentials. And I particularly like his statement about they turned 6,000 staff into 6,000 monitors. And again, that speaks to their trust and belief in the ability and expertise of their frontline healthcare workers. And again, I think many of us saw that or saw parallel actions or parallel experiences during the pandemic as well. And it was, to many of us, very different than how we usually see healthcare working. And so I would ask people to think about their own healthcare experience, their own healthcare systems experience during the pandemic, and think about how their frontline healthcare workers reacted, and how does that align with these resilience engineering potentials and also the idea of the trust and expertise of the frontline healthcare worker.
Great. Okay, Hannah, can you break us up in breakout rooms again, and we will reconvene in 7 minutes.